Good morning. This is Dr. Nithya, Assistant Professor in Department of Obstetrics. So today we'll be dealing with one of the important topics in obstetrics and medical disorder in pregnancy. This is the most common one that we commonly see. That is hypertensive disorders in pregnancy. So in this class, we'll be covering about the classification that contains a variety or a spectrum that includes many categories under hypertension, the main etiology of these and the pathogenesis. The pathophysiology includes the different changes that happen in different organ systems. Is there any way to actually predict the onset of this hypertension in a pregnant woman and whether anything can be done to prevent the same? And how do we manage hypertension in already diagnosed pregnant women? And also if there are any long-term consequences of hypertension in pregnancy. So it complicates around 5 to 10% of all the pregnancies in India. And eclampsia, which is a very severe spectrum of the hypertensive disorders, occurs in 0.05 to 0.5%. That is, if we take 100 pre-eclamptic women, only 1 to 2% of them develop convulsions. Still, it continues to be the leading cause of maternal morbidity and mortality. And if we take worldwide, it is estimated that around 50,000 to 60,000 pre-eclampsia related deaths occur every year worldwide. And it also accounts for many number of near-miss cases. That is 50 to 100 near-miss occurs for every pre-eclampsia related death. So it is a very significant number, and it is also a major contributor to perinatal morbidity and mortality. So even if it is managed well in pregnancy, it is also a risk factor for future cardiovascular system diseases and metabolic diseases. Thus, it also has long-term sequelae apart from its effects on the mother and baby during pregnancy. So if we take the overall causes of maternal mortality in the whole world, if we take, it is contributing to around 18%, and in India, it is contributing to 8% of maternal mortality. This hypertensive disorders of pregnancies, they have variety of spectrum starting from chronic hypertension, pre-eclampsia, eclampsia syndromes, pre-eclampsia superimposed on chronic hypertension, and gestational hypertension. So gestational hypertension is the mildest variety of the spectrum. It means that there is a transient hypertension of pregnancy if there was no pre-eclampsia at the time of delivery, and the BP returns to normal by 12 weeks postpartum. And if after 12 weeks, if we measure the BP and it continues to be high, then we call it as chronic hypertension. So gestational hypertension is defined as a systolic blood pressure more than or equal to 140 or a diastolic blood pressure more than or equal to 90 for the first time, that is diagnosed after 20 weeks of period of gestation and where there is no accompanying proteinuria. And also after the delivery of the baby, within 12 weeks, the blood pressure should return to normal. So the final diagnosis is actually made only postpartum, and that is a retrospective diagnosis can be made for gestational hypertension. Although it is only transient, many of the times it can still be a sign of future chronic hypertension. So the next category under the spectrum is pre-eclampsia. That is nothing but gestational hypertension when it is accompanied by proteinuria. The same definition holds good. The systolic blood pressure more than or equal to 140 or diastolic blood pressure more than or equal to 90 after 20 weeks period of gestation on 2 occasions at least more than or equal to 4 hours apart. Or if the systolic blood pressure was more than or equal to 160 or the diastolic blood pressure is more than 110 millimeters of mercury. So if it is that high, then we need not wait for 4 hours to confirm the hypertension. It can be confirmed even within minutes if the second recording is taken after a few minutes also. The main criteria for the diagnosis of pre-eclampsia is proteinuria apart from increase in BP. So again, pre-eclampsia has 2 varieties, that is non-severe and severe. In severe pre-eclampsia, there are a number of lab abnormalities. The main abnormalities could be reduced platelets or elevated renal parameters or impairment in the liver function test. So the platelet count cutoff is 1 lakh per ml. So if it is less than that, it is considered to be severe preeclampsia. Or in the case of the renal parameters, if the serum creatinine is more than 1.1, or if the doubling time of the creatinine in the absence of any other renal disease is noted, or if the liver function test, when we measure the enzymes like transaminases, aspartate and alanine transaminases, when we see them, so if they are twice the normal concentration, the normal concentration is 35 to 40 international units. So if it is more than 70, then it is considered to be abnormal. Or if there is a pulmonary edema, if the patient complains of cerebral and visual symptoms, then all these will categorize the preeclamptic picture to be very severe. Otherwise, in the absence of these features, it is called as non-severe preeclampsia. So how exactly do we measure the proteinuria? Proteinuria can be measured in many methods. The most reliable one, or the most diagnostic one, will be to do a 24-hour urine collection and look for the amount of protein in the whole sample. So if the measurement of protein is more than or equal to 300 milligrams in the whole 24-hour collection, then it is considered to be proteinuria. Or if we want to do a one-time test and cannot, if it is cumbersome for the patient to collect a 24-hour urine sample, then we can do something called protein creatinine ratio, which must be equal to or more than 0.3 milligrams per deciliter. Or if we have to do a bedside test in a PHC kind of a setup, then we can use something called dipstick reading, which will give the amount of protein in the corresponding colors. So if the reading is given as 1 plus 2 plus 3 plus or 4 plus, so anything, if we see the table corresponding, you can see that 1 plus corresponds to 30 milligram per deciliter. So anything more than or equal to 1 plus on a dipstick also accounts for proteinuria. So if any of these is satisfied along with hypertension, then the patient becomes preeclamptic. So again, as I told you, the term mild preeclampsia has been removed because preeclampsia as such is a multi-system disorder and it has its own effects. So it is called as non-severe instead of mild preeclampsia. So without severe features is when these features are not present, and with severe features means when the systolic blood pressure is more than or equal to 160, or diastolic blood pressure is more than or equal to 110 on 2 occasions, more than or equal to 4 hours apart. Or as I told you, when any of these lab parameters, platelet count, liver function, or serum creatinine is abnormal. Or if the patient complains of any one of these symptoms like severe persistent right upper quadrant pain or epigastric pain, which is unresponsive to a medication, or if there is progressive renal insufficiency, or if there is pulmonary edema and cerebral or visual disturbances, then this comes under severe pre-eclampsia. So what is eclampsia? Eclampsia is nothing but the most severe variety of the spectrum. That is, a patient continuing to have hypertension develops sudden onset or a new onset grand mal seizures, that is generalized tonic-clonic convulsions, in a patient who is already having hypertension in pregnancy. So what are the symptoms which can predict an impending eclampsia? Or what are the warning signs that the patient is likely to throw a convulsion now? If the patient complains of persistent frontal or occipital headache, or if there is blurred vision with photophobia, epigastric pain or right upper quadrant pain that is unresponsive to medications, or if they have reduced urine output or an altered mental status, all these are symptoms suggestive that the patient may likely to have a convulsion. And chronic hypertension means if the blood pressure is more than 140 or 90 millimeters of mercury, that does not satisfy the criteria for gestational hypertension. That is, it occurs much before 20 weeks of gestation or even before pregnancy, then it comes under chronic hypertension. So hypertension, which was first diagnosed after 20 weeks of gestation, or when it is persistent for more than 12 weeks postpartum, then it is called chronic hypertension. So there's another variety called superimposed preeclampsia, when there is new onset proteinuria in a hypertensive patient after 20 weeks of gestation. That is, even if there is proteinuria before 20 weeks, but there is a sudden exacerbation of hypertension, or when there is a need to escalate the dose, then it becomes superimposed preeclampsia. Increase in liver enzymes to an abnormal level, or when the platelet count is less than 1 lakh per microliters, or if any of these symptoms of severe preeclampsia develop in a patient who is already preeclamptic, but they become severe after 20 weeks of gestation. Then it becomes superimposed preeclampsia. So, what are the risk factors for hypertension in pregnancy? One, there is a genetic predisposition. That is, if there is a family history or when the pregnancy itself happens in an Indian ethnicity, then they are risk factors. And regarding the age, extremes of age are at a higher risk of developing hypertension. That is, teenage pregnancy is at a high risk of developing preeclampsia. Or if the other extreme, like elderly pregnancy more than 40 years, then they are at a higher risk of developing chronic hypertension. Even between two normal pregnancies, if the interval is going to be very high, then again they are at a higher risk of developing hypertension. Nulliparous individuals are also at a higher risk of developing hypertension. And partner related factors, when there is a change of partner between two pregnancies, or partner who fathered a preeclamptic pregnancy in another woman, or when there is artificial conceptions like intrauterine insemination or in vitro fertilization, then it becomes a risk factor for developing hypertension in pregnancy. Presence of any other underlying disorders like chronic hypertension, diabetes mellitus, renal disease, obesity before pregnancy or at the time of booking, maternal low birth weight, PCOD, migraine, collagen vascular diseases like SLE or systemic sclerosis, uncontrolled hyperthyroidism, thrombophilia, sickle cell disorders or traits, diseases like APLA, antiphospholipid antibody syndrome, proteinase deficiency, and hyperhomocystinemia, women with excessive snoring or previous preterm birth. All these underlying disorders are also risk factors for development of hypertension in pregnancy. So if we take the pregnancy related risk factors alone, then features like multiple pregnancy, hereditary mole, hydrops fetalis, congenital chromosomal fetal abnormalities, these are all risk factors for development of hypertension. There are also other miscellaneous risk factors like smoking, psychological stress at a workplace, previous history of preeclampsia in the same woman in previous pregnancy, and at the time of booking, if any time diastolic blood pressure was more than 80 millimeters of mercury, these are all the risk factors for developing hypertension in a patient, in a pregnant woman. So what exactly happens in the microscopic level? That is, normally uterine vessels will be invaded by the trophoblastic tissue. So this invasion of trophoblasts happen in two waves. So in preeclamptic women, it is understood that the second wave of trophoblastic invasion is incomplete. That is, the uterine vessels, the myometrium is not completely invaded by the trophoblastic tissue. So culmination of the factors likely involving a number of placental, maternal and fetal factors, and they result in five important etiopathological changes. That is abnormal trophoblastic invasion of the uterine vessels along with immunological maladaptive tolerance between the paternal, maternal and fetal tissues, or when there is maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy, and also genetic, that is inherited predisposing genes are also responsible for the development of hypertension. The most important pathogenesis is trophoblastic invasion. So we can see this is the normal spiral artery, that is the uterine vessels. We can see here the trophoblastic invasion is complete till the complete myometrium. Whereas in preeclamptic patients, if we see these are the spiral arteries and the trophoblastic invasion is incomplete and it stops at a much higher level. So these patients are at a higher risk of developing vasoconstriction to abnormal stimulation. And there are also multiple immunological factors. There is loss of immune tolerance to paternally derived antigens. So if we see microscopically, you can see that there is endothelial damage and proliferation of the myointimal cells. There is excessive insulation of plasma constituents into the vessel wall. So if we also compare, there is a increased anti-angiogenic factors and decrease in angiogenic protein, which is also responsible for the development of hypertension. So what are the biochemical parameters that are increased in preeclamptic individuals? One is an important vasoconstrictor, that is thromboxane A2. Along with that, endothelin 1 and anti-angiogenic factors like SFLT1 and soluble endoglin. These are the factors increased in pre-eclamptic women and which are decreased if we see prostaglandin I2, nitric oxide, or angiogenic proteins like platelet-derived growth factor and vasogenic growth factor. Vascular endothelium derived growth factor. These are all decreased. They are all responsible for angiogenesis. These factors are found to be decreased in patients with pre-eclampsia. So pathophysiology is nothing but what happens in every organ system. It's a multi-organ dysfunction. Pre-eclampsia is a multi-organ dysfunction. So in a cardiovascular system, what happens is hemoconcentration, unduly sensitive to fluid therapy, and in a normal pregnancy, there is expected is hyperolemia, which is severely curtailed in patients with pre-eclampsia. So they have hemoconcentration. And in coagulation system also, there is a reduced platelet, that is thrombocytopenia, and increase in fibronectin. And even in volume hemostasis, we can see that there is reduction in vasoconstricting substances like angiotensin and renin, increase in antinatriuretic peptide excretion. So kidney also there's reduced perfusion and glomerular filtration rate. So there is increase in uric acid, urine sodium, and renal tubular pathology. That is rarely you can see that cortical necrosis can also happen. In the liver, what we see is the periportal hemorrhage, infarction, and subcapsular hematoma because of the distension in the capsule of the liver. So that can lead to severe right upper quadrant pain and epigastric pain. And in the brain, there will be loss of cerebral autoregulation, and visual deficits are also usually temporary. Vasogenic occipital lobe edema can also happen, and non-specific ECG changes. So is there any way to actually predict the onset of hypertension in a pregnant woman? It is concluded that no reliable or accurate screening method is there in low risk population. Only with women with risk factors for pre-eclampsia, which we already discussed, they should be observed more carefully for the development of hypertension and should be offered frequent antenatal visits. Screening to predict pre-eclampsia is beyond appropriate medical history, is not as such recommended for everybody. But if there is an effective screening, it can be only applied for early onset pre-eclampsia that can be achieved in a first trimester itself. So if there is any history of risk factors, then we have to expect that they are having a 2 to 5-fold increase in risk for developing pre-eclampsia. And when we see that the mean arterial pressure anytime is more than 90 millimeters of mercury in the second trimester. Normally what we expect in second trimester is the fall in diastolic BP and the mean arterial pressure. But if there is a rise, or when it is anytime more than 90 millimeters of mercury, then we can use it as a predictor for the development of pre-eclampsia. Then there's something called rollover test where you measure the BP of the patient and then ask the patient to roll over from left lateral position to supine position. You can see that there is an increase in BP by at least 20 millimeters of mercury. So all these are positive signs that you can use them as predictive sign for developing pre-eclampsia. There are also multiple biochemical parameters you can see in the urine and blood, which are also having very less sensitivity and they are not useful very practically. So what can be seen in urine is the hypocalciuria, urine albumin creatinine ratio, kallikrein creatinine ratio, and microalbuminuria. All these are urinary biochemical parameter for screening. And in blood also there are many biochemical parameters which are found to be increased like HCG, maternal serum alpha fetoprotein, inhibin, activin, homocysteine. These are all fibronectin and corticotrophin releasing hormones. They are all increased in patients with higher risk of developing preeclampsia. But some factors like placental growth factor, SFLT1 and placental protein 13, they are all decreased in patients who are at a higher risk of developing preeclampsia. So since there is no effective way of prediction, we can only anticipate in patients with risk factors. So there is something else that we can actually do in the mid trimester, that is a late first trimester or early second trimester, that is around 12 to 14 weeks. If we do a uterine artery Doppler, it can predict the onset of preeclampsia to some extent. So what we notice is increased resistance to blood flow within the uterine arteries, and so it gives an abnormal waveform pattern. You can also see that there is an increased resistance or pulsatility index, or when there is a persistence of diastolic notch, which usually disappears in the mid-trimester, then it's a better predictor of early onset hypertension in pregnant women. So the major pitfalls are that it is mainly operator dependent and it has a poor predictive accuracy. No improved maternal or fetal outcome who underwent this screening. So here we can see that this is the normal systolic flow and this is a diastolic flow. Usually this notch doesn't happen. So if the notch is persistent, or if we see that the diastolic flow itself is very much reduced, then we consider it to be a predictor for preeclampsia. So is there anything that we can do to prevent the development of preeclampsia in a patient who is at a higher risk? So there are many things that have been tried, that is starting from non-pharmacological interventions like lifestyle changes, regular antenatal care, regular physical activity. Bed rest or activity restriction is not recommended in pregnancy, and weight reduction is also not recommended in pregnancy. Even in obese patients, it is not recommended to reduce weight at the time of pregnancy. So pharmacological interventions like antihypertensives, which are used prophylactically, they also show no reduction in incidence. Diuretics are not recommended. Hyperhomocysteinemic individuals is to some extent folic acid and B6 is beneficial. Heparin with or without aspirin, again no sufficient data has been available except in certain conditions like patients with antiphospholipid antibody syndrome. Nitric oxide donors, again they have no sufficient data. So all these have only been trialed and used in studies. So nothing has been recommended. So there's only one thing which is recommended, that is calcium supplementation, 1.5 to 2 gram per day. And one more thing is aspirin, 150 milligrams at bedtime in a patient who is at a higher risk of developing preeclampsia. So only these two are being used practically. There are other many things that have been tried, but they have been shown to have no benefit, like sodium restriction in the diet, or dietary energy intake, protein intake, or fatty acid supplementation. Even micronutrients like zinc, magnesium, folic acid, vitamin B, all these have been tried and proven to be in vain. So even only there are two things which could be tried to prevent the onset of preeclampsia. One is high dose of calcium, and second is aspirin at a dose of 150 milligrams, starting as soon as you see the cardiac activity on ultrasound. So there was a trial called CLASP trial, which said that use of aspirin is associated with many. So they do not use recommended routine prophylactic or therapeutic administration to all the women at risk of preeclampsia. And then came the NICE guidelines, which says that women with high risk factors or more than one moderate risk factors, then they are at a higher benefit from aspirin if we start supplementing them from early pregnancy. Okay, how do we manage a woman with antepartum preeclampsia or hypertension? So if we see gestational hypertension and preeclampsia without severe features, then the patient may initially require admission only for the initial evaluation, and then further it can be managed on an outpatient basis. So at the time of diagnosis, what we do is BP charting along with continuous maternal evaluation. So these investigations are sent for the mother, that is complete blood count with platelet count, renal function test, liver enzymes, urine protein, either a 24-hour urine sample or a urine protein creatinine ratio. And also she's asked for every day about the impending symptoms of severe preeclampsia. And about the fetal evaluation, we do an ultrasound for estimated fetal weight and amniotic fluid index. We also do a non-stress test and a biophysical profile if the NSG is non-reactive. So after admission also, we continue the maternal evaluation if there is no indication for termination. Again, we have to do the BP every twice a week, and then urine protein at each antenatal visit at least weekly. And these investigations also have to be repeated every week. Regular diet with no salt restriction. And for the fetal evaluation, we advise the patient to have a daily kick count, and ultrasound is done every 2 to 3 weeks to look for signs of IUGR. And the LICA status is also assessed weekly. A non-stress test is offered for all hypertension women weekly. In case of any reduced fetal movements, then anytime admission. Sorry. Like this, hypertension can be managed up to 37 completed weeks unless there is any indication for termination prior. Like when the period of gestation is more than or equal to 37 weeks, or when there is suspected abruption, or when the patient has severe features, that is labor or rupture of membranes, abnormal fetal evaluation or maternal evaluation, or when there is IUGR and oligohydramnios, or if the persistent biophysical score remains less than or equal to 6. So if there is none of these features, then we can continue the pregnancy up to 37 weeks with the continuous monitoring. Or if there is any of these features, then they have to deliver the patient immediately. Delivery could be vaginal or cesarean depending upon the obstetric indications. So if we take pre-eclampsia with severe features, then the pregnancy has to be terminated much earlier, that is at 34 weeks itself. So if the pregnancy is less than 34 weeks, then we have to admit the patient and observe in labor and delivery. Then we have to give magnesium sulfate prophylaxis and start the patient on antihypertensives. So if there are no contraindications to expectant management like eclampsia, pulmonary edema, DIC, uncontrollable severe hypertension, or if there is abruption with intrauterine death or a non-viable fetus, then we can continue with monitoring up to 34 weeks. And then also give antenatal corticosteroid, and then we can deliver the patient after 48 hours. If there are no such features and we continue expectant management, we can deliver once the maternal condition is stable or after 34 weeks of gestation. So what antihypertensive drugs? The target for starting is more than or equal to 150 by 100. So commonly used antihypertensive drugs are alpha-methyl dopa, which is started at a dose of 250 milligrams per oral TID, and labetalol, which is started at 100 milligram BD, nifedipine, which is started at 10 milligram PID, and atenolol, which is used mostly postpartum. It is not used in the antepartum period. So labetalol is a combined alpha-beta blocker. Nifedipine is a calcium channel blocker, and methyl dopa has central action. All these can be used. The first line which is usually used is labetalol. So even in severe hypertension, the same drugs can be used, but labetalol can be given intravenous instead of an oral dose, that is 20 mg IV stat followed by 20 to 40 minutes. It can be repeated after 40 minutes. Maximum dose can be given up to 300 milligrams. Similarly, nifedipine can also be given repeatedly after every 30 minutes, maximum up to 50 milligrams. So the postpartum care, again, blood pressure has to be measured at least 4 times per day during the inpatient care. And then we have to make sure that blood pressure is seen once between day 3 to day 5. Again, we have to call the patient after 12 weeks to make sure that BP has come back to normal. Only then it is gestational hypertension. Otherwise, it will be chronic hypertension. So the neonatal complications that are expected will be preterm delivery, fetal IUGR, hypoxic neurological injury, perinatal death, and long-term cardiovascular morbidity associated with low birth weight. So eclampsia is nothing but onset of seizure in a woman with pre-eclampsia. It could be antepartum, intrapartum, or postpartum. So we immediately call for help and then establish the airway, administer MAC-self, catheterize and monitor urine output, and control of hypertension is important. And the investigations that we have already discussed has to be set. So delivery within 4 hours after stabilization. Vaginal route can be done. If the delivery is not imminent, then cesarean section is preferred. Magnesium sulfate is a drug of choice that we give in eclampsia, and We have to make sure that we monitor the deep 10-1 reflex, respiratory rate, urine output, and oxygen saturation when we are administering MAC-self. The most commonly used regimen is the Pritchard regimen, where we give 4 grams IV over 5 minutes and 5 gram IM into each buttock as the loading dose. And we continue the maintenance dose as 5 gram intramuscular every 4 hours into alternate buttock. So this has to be given for 24 hours from the loading dose or from the seizure, whichever is later. We see that if the most severe side effect the patient can have is respiratory arrest. So when they develop respiratory arrest, we have to stop magnesium sulfate immediately and give the antidote, that is calcium gluconate, which is given as 10% solution, 10 ml over 10 minutes. A patient who has eclampsia can also develop placental abruption and neurological deficit, aspiration pneumonia, pulmonary edema, and cardiopulmonary arrest. Maternal death can happen in around 1%. So when there are successive convulsions without regaining consciousness in between, it is called status epilepticus. HELP syndrome is nothing but again a complication of severe preeclampsia where there is hemolysis, elevated liver enzymes, and low platelets. There is no specific management for HELP syndrome other than stabilizing the platelet count and delivering with the patient. We have to take care of the blood pressure also. Chronic hypertension is again managed in a similar way with antihypertensive and blood investigation. Delivery has to be done at 37 completed weeks. So the long-term sequelae include recurrence in next pregnancy and cardiovascular and neurovascular morbidity, ischemic heart disease, stroke, chronic hypertension, and type 2 diabetes. They can also have renal sequelae and neurological sequelae. Thank you.